Good morning, friends. Myself Abhishek Kadea, intern, ZS Medical College and Hospital, Dahod. Today we'll presenting the topic of electroconvulsive therapy under the guidance of Dr. Manu Parmar sir, HOD of Psychiatry Department. Today, first of all, we discuss about the certain misconceptions. You have seen in various films that it is wrongly presented that electroconvulsive therapy leads to severe brain damage, permanent memory loss. So today we, along with my co-intern, will clear you all the myths related to is electroconvulsive therapy.
ECT is painful.
So no, reality is not like that. ECT is given under general anesthesia with muscle relaxations. The patient does not feel any pain sensation during this procedure.
ECT causes brain damage.
There is no scientific evidence that the ECT causes structural brain damage. It is considered safe when it is properly administered.
ECT is used as punishment or control.
ECT is a medical treatment used only with a clinical indication and informed consent.
ECT permanently destroy memory.
No, it is not like that. It is wrongly presented in various films we have seen. So it only leads to temporary memory loss, especially around the time of treatment. It can only occur. Then it reverses gradually.
Right.
ECT is outdated and barbaric.
No, it is not like that. Modern ECT is highly refined, evidence-based, and still used worldwide, especially for severe mental depression, then catatonia and treatment-resistance cases.
ECT is only for mad or violent patients.
No, it is absolutely myth. ECT is commonly used for severe depression, suicidal patients, bipolar disorder, and catatonia, and it is not only used in violent patients.
ECT changes personality.
No, it is not like that. ECT does not change personality, but it enhances your mood and make patients seem different because the symptoms are already relieved.
ECT should be the last resort in all cases.
No, it is not like that. While often used after medications fail, ECT may be a first-line treatment in life-threatening conditions like severe suicidal depression thoughts.
ECT is dangerous and often fatal.
No, it is not like that. Mortality risk is extremely low. It is comparable to minor surgical procedures under anesthesia.
ECT works only because of fear or placebo effect.
No, it is not like that. ECT has proven neurobiological effects and high efficacy, especially in severe depressions. So, after clearing all the myths regarding electroconvulsive therapy, we will discuss it in detail.
Okay. Thank you, Dr. Abhishek, and thank you, Dr. Lakshmi. Chalo.
Bas. Okay. So now we will discuss in detail about electroconvulsive therapy. So what is electroconvulsive therapy? It started in 1930s with the idea of using scissors to treat the mental illness. Electroconvulsive therapy that involves a brief electrical stimulation of the brain to induce a seizure. Unmodified ECT became popular but was often harmful due to lack of safety measures. Modern ECT. It is safer with anesthesia and muscle relaxant, is effective for severe depression and other conditions when other treatments fail. Electrophysiology. So in this will seizure induction and propagation. Electrical stimulation. Brief electrical pulse is delivered to the brain, triggering neuronal depolarization. Seizure onset. The depolarization spreads rapidly across the cerebral cortex, leading to a synchronized neuronal discharge. Seizure propagation. The seizure activity propagates to the subcortical structures, including thalamus, hypothalamus, and brainstem. Neurotransmitter systems. It increases the neurotransmitter release norepinephrine, serotonin, dopamine, and GABA. Long-term neurophysiological effects: synaptic plasticity, neurocircuitry remodeling. Neurotrophic factors. It includes increased neurogenesis. ECT promotes the growth of new neurons in the hippocampus, a brain region involved in learning and memory. Increased neurotrophic factors. ECT upregulates the expression of neurotrophic factors such as brain-derived neurotrophic factor, which supports neuronal survival and plasticity. EEG changes. First of all, we will see seizure pattern because in this we induce the seizure. EEG recordings during ECT show characteristic pattern of electrical activity, including initial spike wave complex, followed by a period of generalized slow wave activity. Post-seizure changes. After the seizure, EEG may exhibit increased alpha and theta activity, reflecting changes in cortical arousal and inhibition. Now, mechanism of action. Neurotransmitter modulation. Increased neurotransmitter release like serotonin, dopamine, norepinephrine, which play a crucial role in mood regulation. Altered receptor sensitivity. Changes in the sensitivity of neurotransmitter receptors can affect the balance of neurochemical signaling. Neurotrophic factors induction. Upregulation of neurotrophic factors like BDNF and other neurotrophic factors. Neurocircuitry remodeling. Functioning connectivity changes. ECT can alter the functional connectivity between brain regions, particularly those involved in mood regulation and cognitive control. And then now we'll discuss about the indications of electroconvulsive therapy. Major depressive disorder, mania, schizoaffective and related disorders, and catatonia. Now
Postpartum psychosis.
Postpartum psychosis also we'll see. And uncommon indications are autism, dementia, Parkinson disease, epilepsy, neuroleptic malignant syndrome. Pre-CT evaluation. Pre-CT evaluation, check the compliance with the pre-treatment orders, review mental status, review medical records, dry clean hair without cream or dampness, establish IV access, record baseline vitals, and establish airway oxygenation. Pre-treatment evaluation is done physical, neurological, and pre-anesthetic examination and complete medical history. X-ray, CT scan, pre-operatively are also done. Then preparation for SCT procedures, it includes overnight fasting. It is administered in fasting condition after late intake of clear liquids of minimum 2 hours, milk and light meat so 6 hours, fried food, fatty food or meat over 8 hours. Head should be dry and clean before the procedures. Medication should be avoided before the procedures include high doses of antihypertensive, thyroxine, antiemetics, anti-anginal, bronchodilators. Pre-medications during ECT are NBM before 6 hours of the procedures. Most common drug is atropine 30 to 60 minutes before the anesthesia. Now anesthetic part, which include modern ACT includes anesthesia. So which anesthetic is given? Most common drug is methotrexate 0.75 to 1 milligram per kilogram IV bolus. It is a shorter duration of action. Alternative are etomidate can also be given. Ketamine, propofol, and alpha-fentanyl. Then muscle relaxant. Most common muscle relaxant uses succinylcholine 0.5 to 1 milligram per kilogram IV bolus or drip. Then electrode placement. Electrode placements are bifrontal, then biotemporal, and right unilateral is also given, but most common is bifrontal. Electrical stimulus is also given in this procedure to induce a seizure. Then complications during ECT. It includes missed seizure, inadequate seizure, prolonged seizure. These are dependent on seizure threshold. The seizure threshold is generally lower in young subjects, manic patients during the first ECT session. Adverse effects of ECT are tardive seizure, post-ictal confusion, joint pain, headache, phobia, and anxiety towards ECT. Number and spacing of the treatments. ECT is generally given twice or thrice a week depending upon the symptoms. Twice weekly is used to have the best balance between the therapeutic outcome and the adverse effects. Spacing. There is no fixed number of sessions, but it depends on the consultancy and revealing of the symptoms. The number should be decided based on degree and rate of clinical improvement. A typical course of HCT for depression, it includes 6 to 12 sessions. If the patient does not show noticeable improvement even after 6 sessions, then a change in the technique is considered. Monitoring. Seizure monitoring, cough method and EEG method. There are two methods to monitoring the threshold of the seizures during this procedure. Cough method and EEG method. Other physiological monitoring are pulse, BP, SpO2 ECG also. Adequate seizure given is earlier definition of 15 seconds of motor seizure and 25 seconds of EEG seizure to define an adequate seizure. Is found to be of little clinical prognostic benefit. Good quality motor seizure involves different stages. Initially, there is a gradual seizure induction during the stimulation. Bilateral conversions will emerge with and gradually. A comatose stage will succeed the conversions with the gradual regaining of conscious and orientation. Thank you.
Thank you, Dr. Abhishek.
Thank you, Dr. Lakshmi.